Thank you for inviting me. Epistop is actually a huge project, and I'm really happy that you're moving forward. And as Sergius told you, actually in the next few months we will have major results, and I hope that they will confirm what we all think about epilepsy and tuberous sclerosis. So my task is to talk about EEG in tuberous sclerosis, and especially concerning the Epistop trial. And you might find a lot of schedules like this if you talk about epileptogenesis. So this is a recent work by Pitkanen, and actually what I retain from that slide is that there are many causes of epilepsy, as you all know. The genes are just one possibility, but status epilepticus, neurodegenerative disease, metabolic disease, they can all lead to epilepsy. And in some way, we are actually finding a final common pathway, and that's still very difficult to understand. You have these different etiologies, and at some point, they decide to go on and to develop epilepsy, and that's what we call epileptogenesis. And for some children, that will never lead to clinical seizures. In others, the seizures will arise, and then we'll talk about clinical epilepsy. So we need biomarkers, and that's what's on top of this. We have susceptibility biomarkers, diagnostic biomarkers, prognostic biomarkers. We really need these to be able to predict who will develop epilepsy, who will develop epileptogenesis, and who will actually become refractory, drug-resistant epilepsy, who has a lot of comorbidities, yes or no. So the need for biomarkers is really great, and Epistop will help us to define these biomarkers. Now, there are actually all epilepsies are interesting, but there are a couple of situations where we know that children, infants, adults will most likely develop epilepsy. Like for instance, in hypoxic ischemic encephalopathy, it used to be like 30% of all these children would develop epilepsy. Now with the cooling, it's going down to 20%. Tuberous sclerosis, still 80% of these children will develop epilepsy, or even 90%. So we know that if a child is born with tuberous sclerosis, that the incidence of epilepsy will be very high. Trisomy 21, many of these children would develop infantile spasms. So if we would be able to understand why a particular child with trisomy 21 or tuberous sclerosis will develop epilepsy, I think it's opening the possibility to treat earlier, and that's all about Epistop. Also, some of the very well-known epilepsy syndromes, we know, like West syndrome, some of these children do very well afterwards, not too many actually, but some develop a really drug-resistant epilepsy, what we call then Lennox-Gastaut syndrome, which is only the endpoint, a clinical endpoint of a very severe epilepsy. So to understand who will develop Lennox-Gastaut, this is what we really want to know in the epilepsy world, and Epistop will help us. Now, they defined, again, that new paper still to be published, they defined all sorts of biomarkers, and actually we are looking for biomarkers for epileptogenesis. Now, my question is, EEG, does it play a role? Is it an ideal? Is it a biomarker to follow epileptogenesis? So that's one of the sub-questions in the Epistop trial. And the idea is very simple, and Sergius already mentioned it. Actually, we do believe that EEG changes, and especially epileptic discharges, but also background activity changes, that do reflect epileptogenesis. So they say there is something going on. And we also know, and that's still to be examined actually, the more severely the EEG is disturbed, the more likely clinical epilepsy will start. Actually, that's something we have to examine. We don't know that yet. The other idea is the younger you start with your epilepsy, and I think that's true for all epilepsies, if you're below the age of 1 and you have a starting epilepsy, which is difficult to treat, most of these children, actually almost all of these children, will have a bad developmental outcome. So if you could interfere, again, Epistop, with early epileptogenesis before the start of clinical epilepsy, perhaps we will be able to make the outcome better. And again, that's the major aim of Epistop. Now, can we use EEG as a marker for epileptogenesis? And there are lots of animal data, and I can show you a couple of examples. For instance, this is a traumatic brain injury model, which is very famous actually. And what you usually see in these models is that first you see the spikes, and only later you see the epilepsy. So in these studies, it is confirmed that after traumatic brain injury, first you have EEG changes, and then you have clinical seizures. And even more in detail, if you look at what sort of abnormalities they see, these are actually in all these animal models and also in humans, high-frequency oscillations. That's something we don't see on a clinical EEG, but if you look for it with changing your parameters of the EEG, you can see high-frequency oscillations. And they appear first, and then only later in red, you see the appearance of seizures. So what about this high-frequency oscillations? This is another study, a very recent study, also in traumatic brain injury. And what they saw, so this is traumatic brain injury, and with time, first you see the high-frequency oscillations, and then they become associated with spikes, and that's the time where you would see it on the clinical EEG. Then you have a disturbance of sleep spindles, and actually that's another thing we can examine in our Epistop huge data set of EEGs. Many of the epilepsies have disturbed sleep spindles, and then they have clinical seizures. So in this model, again, it starts with high-frequency oscillations, and then later on with high-frequency oscillations associated with spikes. Now, this is not a new concept, the high-frequency oscillations. This was a clinical paper already 10 years ago, looking at EEGs of children with epilepsy, not tuberous sclerosis. And we all know in clinical practice, we would say this is abnormal, this is very sharp, this is a spike. But if you look at more carefully in detail, they mentioned that there is sometimes also like these bursts of very high frequency spikes, not very high frequency, 20 to 30 hertz. But the point is, if they look at the progression of these children with epilepsy, if at the beginning they had no paroxysmal high frequency abnormalities, and they would go to a focal abnormalities, so high frequency oscillations focally, most of these children would get worse. So the appearance of these high frequency abnormalities on the EEGs would predict that these children would get worse epilepsy. But this is already 10 years ago, and I will show you in a moment a more recent paper. So do we have, if you move from animals to humans, do we really have a lot of evidence? So the question is, do we have data with prospective EEG data? Because that's what I want to examine, is EEG prospectively a marker for epilepsy? And I think also for humans, we have a lot of data in traumatic brain injury, especially in adults. We do have a couple of papers on febrile seizures. We have lots of papers on West syndrome, actually. And usually these, and I will show you, these papers or follow-up papers of children born with hypoxic ischemic encephalopathy, and they would do every month an EEG, and some of these children will develop West syndrome. And we have now with Epistop, of course, we have lots of data on tuberous sclerosis. Now, to give you a couple of examples, so I'm not talking about tuberous sclerosis yet, but about children with West syndrome, infantile spasms. This is an old paper, and they followed up these children with hypoxic ischemic encephalopathy. Some of these children would remain normal, and some of these children would develop EEG changes. And the interesting part of that study, and I think it's still true and valid, but we have to prove it with our data, that sometimes you reach a point at the EEG level with abnormalities, and I would call this a point of no return. If you reach that level of EEG abnormalities, and it's very logical, then it will go on and gets worse and worse and more difficult to treat epilepsy. So this is the first phase in that study, and then usually you see in the occipital leads some sharp activity, and this is still reversible. This can still be associated with normal outcome, with no appearance of clinical epilepsy. But if you reach that level and you say, oh yes, but this is multifocal epilepsy, this is the point of no return. All these children in that particular study went on to develop very severe epilepsy. And this is, of course, the worst phase, that this is like hypsarrhythmia. Another study showed exactly the same. First abnormalities always in the occipital regions, and that's something that we want to examine again in Epistop. But this seems to be a pattern that the occipital lobe is more epileptogenic than other lobes. And you see it gets worse, and then it develops into pattern D in that study. So you can actually predict some of these patterns by looking at earlier EEGs. This is one of the better studies, I would say. It's not a large series. These are 12 children, and they looked at the evolution before the onset of epileptic tonic spasms. And again, most of these children, before the onset of clinical seizures, they would have focal spikes or paroxysmal fast activity. FA is fast activity, and then hypsarrhythmia, and then at some point they would have clinical spikes. Here another example. This is a child already with a lot of spikes. He had already focal infantile spasms here, and then you see the evolution. But there are also children with focal spikes who never developed tonic spasms. So the message of that paper was, before the onset of your typical infantile spasms, you will see in lots of these children focal spikes, and you also will see these fast activities that we actually overlook when we look at a normal EEG. Now, this study was mentioned by Sergio, so this is now tuberous sclerosis for the first time. And actually, that's at this moment a unique study looking at the sequential EEGs in children with tuberous sclerosis. As Sergio was explaining, they looked for 1 year in that study, and all children with tuberous sclerosis. They did EEGs every 4 or 6 weeks. And the first EEG abnormalities in the cohort was around 4.2 months. And the onset of epilepsy, there was a delay of about 2 months. And the interesting part of the study was that if you would develop spikes on your EEG during the follow-up, all of these children will develop clinical epilepsy. So this is a very strong message. I don't think it's true for all children. But in that study, if the children during the follow-up would develop spikes on the EEG, all of these children will develop seizures. So the clinical message for all of us is please do EEGs in all these children. If you see spikes, there's a high likelihood that the child will develop seizures. Sergio showed you already this table, but this is a more recent study in 2018, going back to this probably very interesting notion about high frequency oscillation. So I talked about paroxysmal fast activity. You can call it high frequency oscillation. It depends on the frequency. So this is what we see on a normal EEG, and most of us would say this is abnormal. This is an abnormal transient, it's a sharp wave or even a spike. Now if you prolong it, that's what you will see. And then if you play with your settings of your high frequency filters, you will see that these fast activities will appear. Even activity of 250, the frequency of 250 will appear, and you will never see it on a normal EEG. So we should look at these high frequency oscillations. The problem is you cannot do it retrospectively. The interesting part of this study, but this was done in tuberous sclerosis, looking at these high frequency oscillations. In the control children without tuberous sclerosis, none of them had high frequency oscillations. And if you look at the children with tuberous sclerosis developing epilepsy, all of them had high frequency oscillations. So I think that's a really important notion. But it's a pity because prospectively we can now think about high frequency oscillation and change the settings of our EEG machines. We cannot do it retrospectively on the EEGs we got from Epistop. Now Epistop, the last part, again, we don't have too many results. We are really working very hard on this. It's very complex, but we will get a nice results. So for the EEG part, what we asked to do all the clinical sites is to do serial video EEG recordings for at least 1 hour, including at least one sleep and wake cycle with the typical 19 electrodes, typical 1020 systems. And we would ask the local centers, so the 9 centers all over the world, actually more in Europe, to score these EEGs with a predefined scoring system. And then in Leuven, this is work package 2, we would do a more in-depth reading of the EEGs afterwards to look at localization of all the spikes and to look at background. We needed the local scoring because in the randomization part of the study, it was important to have immediately a reading of the EEG so that we could randomize the children to or nothing, or standard of care, or preventive vigabatrin. So this is just a short notice of what we call the scoring. Scoring was looking at epileptic discharges, for instance, and you could say there is no epileptic discharge, or there is hypsarrhythmia, which is D. One brain area is involved with epileptic activity in one hemisphere, which would be an A. So we asked for all EEGs, and there are more than 1,600 EEGs collected during the study, to score if there were epileptic spikes, and also the frequency or the severity of the epileptic discharges, which would be 1, very rare, less than 1% of the time, 3, 10 to 50% of the time. So for every EEG, we had a local simplified score, and this was based on the work that was also done by the group of Sergius in Poland. So in the Epistop trial, there was a randomization part, so the parents could sign up for randomization. That means that they would agree that we would do EEGs every 4 weeks, and if the child or the EEG was becoming worse and worse and reached that threshold, then the child would be randomized to or standard of care or vigabatrin. Standard of care would mean I will follow the child, and if the child develops spasms, I will give vigabatrin or steroids or whatever. Preventive would say, yeah, your child doesn't have epilepsy yet, but it's severe enough, and we will randomize it to vigabatrin. So from now on, your child will have vigabatrin. Of course, if we saw on the EEG seizures, subclinical seizures, we would always randomize to treatment. So this is the way it worked. Two slides on the results, and I got these results from my fellow Jesse de Ridder, who is also here in the audience. So we looked at the available data, 94 children in the Epistop trial with already a follow-up. Actually, they all have a follow-up of 2 years, but now 1 year. We see, and this is not surprising, but still it's frustrating to see that at the age of 1 year, more than 90% of these infants already had an abnormal EEG. I'm not talking about seizures yet. So actually tuberous sclerosis equals epileptogenesis. If you believe that EEG changes are reflecting epileptogenesis, almost all of these children, 9 out of 10 children, do develop spikes, do develop epileptic abnormalities on the EEG. So, and if you then believe that the occurrence of spikes on the EEG is the precursor of clinical epilepsy, I think this is a very important message, and it's in all the guidelines right now. Probably you should do serial EEGs and all of these children with tuberous sclerosis and decide early on which one will need medication. So this was one result, very simple result, not surprising, but still frustrating. It's a terrible disease, actually, if you look at EEG changes and epilepsy. Now, what about seizures? So now this is looking at the same cohort after 1 year. So we will have data for 2 years, but after 1 year, how many did have seizures and how was the EEG? Let's first, this is another slide, I'm sorry. Let's first look at the more details about the EEG changes. So here I told you that almost all of these children develop epileptic abnormalities. So the question is, what sort of epileptic abnormalities? And you see that if you look at the first abnormal EEG, this could be after 1 week after birth or after 3 months. Some of these children had normal EEGs for a couple of months and then developed abnormal EEG. So if you look at the characteristics of the first abnormal EEG, this was usually seen around 2 months, with a big range, of course. And if you look at what is seen on that first abnormal EEG, A meant monofocal, unifocal, left occipital, right frontal. So this is like 1/4 of the children. But then B and C is actually in different areas of the brain or really multifocal. So the first EEG was already multifocally disturbed in 71% of the children. So that means you start doing all these EEGs, but actually the first one is already terrible, is already B or C. To our surprise, there was not a single child with hypsarrhythmia as a first abnormal EEG in this cohort of 94 children. Now this is about seizures, so EEG is something else than seizures. So we also looked at subclinical or clinical seizures after 1 year, and it's a bit lower than in the literature, 55%. But we have to realize that in some of the centers who participated, standard of care already means preventive treatment. So I can hope that the fact that this is a bit lower than in the literature already indicates that preventive treatment in some of the centers, like in Rome or so, that this lowers the incidence of epilepsy. Now, if you combine it with EEG, so at 1 year, 54% of cohort had clinical or subclinical seizures. Now, if you remain with the normal EEG, chances are very low that you will develop epilepsy, but it's 1 out of 7. So having a normal EEG is still a good sign. If you have an abnormal EEG, of course, most of these children had at least 1 abnormal EEG, but the interesting part is if you correlate the seizures with the first abnormal EEG, there was not a statistical correlation. That means that it's not because your first abnormal EEG is multifocal that you're more likely to develop epilepsy. You can also develop epilepsy if it remains at A. So it is a bit higher here, 60% versus 48%, but this is of course not statistically significant. So it's a bit tricky because you follow these children. The first EEG can be a B or a C or a D, and some of these children will develop epilepsy. Some of the children with an A will also develop epilepsy, so it's not very predictive. So to conclude, I think Sergius also said that this is it's a fantastic model, in brackets, for studying epileptogenesis, tuberous sclerosis. We found so far, but of course more data will come, that at the age of 4 months, 80% of the children had already an abnormal EEG, and in the majority these were already multifocal discharges, and there was no significant association between the epileptiform discharge of the first abnormal EEG and the later occurrence of subclinical seizures, which is a bit a pity and frustrating, of course. 47% developed clinical seizures. I told you 54 developed epilepsy, which is subclinical or clinical seizures. About half developed clinical seizures, less than in the literature. Epileptiform discharges did precede the onset of clinical seizures in the large majority of the children, and there was an interval. In the American study, it was 1.9 months. In our study, it's 2.5 months. So that means the interval between the first abnormal EEG and the occurrence of clinical seizures is 2.5 months. So to end, the last slide, I think we still have to look in more detail to all the EEGs. We have more than 1,500 EEGs. So we should not only look at spikes, but also at background changes, sleep analysis. The localization probably is very important. I can imagine, but I don't know, that if you have frontal spikes, that they are more likely to have difficult to treat epilepsy than temporal spikes. I don't know. We have to look at this. We also need to look at more automated EEG analysis, but this is very difficult because most of the EEGs are in young children with a lot of fluctuations. I'm not sure that it will work, but we still need to try to do more sophisticated EEG analysis. And of course, the final check is to combine our EEG data with imaging, molecular and genetic findings. This is of course the aim of the whole Epistop trial. Thank you very much.
So I'm going to look at the box. Am I allowed to allow one or two quick questions? So, fascinating. I think a remarkable study that you're getting towards the end, but now in a way it sounds as though the hard work begins.
Yeah.
Now that everything's in the bag. Chance for one or two burning questions. Anybody wants to ask about this data project? Or make a comment about it? No, you're not allowed to make a comment. Others can. Do you want to make a comment about it?
Yeah, maybe I just wanted to highlight indeed what you said about the prospective EEG follow-up. It means that if we have a diagnosis of tuberous sclerosis, we really have to educate the parents about the fact that spasms and focal seizures can occur. And I sometimes find it, I mean, you can explain it, you can show movies, so then you think like, I'm doing a good job. And sometimes it just still is so difficult because people know, you've shown them, infantile spasms, also focal seizures. I think it's very difficult in the very young ones to show parents really what it can all look like. And then sometimes they see it and then they will see you and then you ask like, how long has your child been doing this? And then they'll tell you, yeah, I think for at least 2 weeks. And then despite all the explanations, it's still a challenge to make sure that even you tell them, they go through a process of accepting that what they're looking at is probably really epilepsy and that they really should get in touch with you. But I find it quite tricky. And I also think the comment that was made earlier by Lisbeth about the spasms, if you don't have a diagnosis of TSC because there was no prenatal signs or the pregnancy was not followed, so out of the blue comes spasms, I think it still is a challenge to make sure that people, pediatricians, first-line people recognize spasms. I had one with full-blown hypsarrhythmia in the clinic on the consultation this week, and it's just because it was there this week that I just still get so frustrated over it. It's really challenging. And I think the campaign that be-TSC has been doing on the infantile spasm, just to raise awareness first with first-line physicians, is still so important because otherwise we're investing so much effort in this kind of study to prevent and to have a better outcome. But if people are not diagnosed, then this is just all the advantages are just wasted. So I think it's still very important that even if we have sophisticated biomarkers, we really educate and make sure people recognize. Long comment, sorry.
That's fine. Does that trigger the question for anybody? Or shall we allow Sergis's comment now?
Yeah, it's I think for the first time when we have such big data. So Lieven analyzed, I think, more than 1,500 EEGs.
I didn't do that.
So it's a huge amount of EEG recordings. And for the first time to analyze, just to set properly the threshold, it's very challenging, very difficult. So there is the question that we are discussing about that when should be the threshold.